Hello dear friends. So today we have this question on gallstone ileus. So this gallstone ileus is basically a biliary enteric fistula, and this is secondary to a large gallstone erosion into the duodenum. Impaction is most commonly seen at 60 centimeter proximal to ICJ. The most common site of this biliary enteric fistula is between gallbladder and duodenum, and second most common site is between gallbladder and transverse colon. Now the sign and symptoms, it presents with signs and symptoms of intestinal obstruction. There will be pain, there will be abdominal distension, vomiting, and there will be history of gallbladder stone disease. This is important. The pain here will be episodic and recurrent, and there will be tumbling obstruction. So basically there is a ball value effect, there is recurrent and relapsing episode of obstruction because of this gallstone. Now on radiology, on X-ray, as you can see in this first image, there is regular stride, and this regular stride is basically the first thing here. This is pneumobilia. There is air in the biliary tract. So one more condition in which will you find pneumobilia, there is ERCP and sphincterotomy. So besides pneumobilia, second thing is small bowel obstruction, as you can see marked as 2, small bowel obstruction. And third thing is there is atypical mineralized shadow on the radiograph of a stone. So these three things, they form regular stride. Now there is one more term known as regular sign. So this is seen in perforation mainly, and in this regular sign what you find on radiology on X-ray, so you are able to see the wall of a bowel. So because there is air inside the bowel, that is intraluminal air, and there is free air which is outside the bowel, that is extraluminal air, and because of which you will be able to see the wall of the intestine, and this is known as regular sign. So this is not a regular sign is not a the part of the gallstone ileus. So this is seen in perforation, cases of intestinal perforation. Now this regular stride, this is pathognomic for gallstone ileus. If two of these features, 2 out of 3 features they are seen, it is pathognomic of gallstone ileus, and it is seen in 40 to 50% of the case of gallstone ileus. Now how to manage this? So treatment is basically surgery. So what you do, so you do a laparotomy, and after laparotomy the stone is milked proximally. If there is obstruction at 60 centimeter from the ICJ, you have to milk the stone proximally. So you milk it proximal, and then you do an enterotomy and you remove stone from that site. So this is how you manage this gallstone ileus. Then one more thing to note, if the stones are faceted, so you have to look for other stone as well in the intestine. So there can be other enteric stone as well. Now one more important thing in this gallstone ileus is whether to operate the gallbladder region or not. So if your patient is stable, then you can do one thing, you can manage this gallstone ileus, along with you can dismantle the fistula and manage the fistula as well. So you can do single stage procedure. But if your patient is unstable, then you do only enterotomy for gallstone ileus, and you keep gallbladder area surgery for second stage. So this is how it is managed. Then one more important term here is Bouveret syndrome. So Bouveret syndrome is basically there is duodenal obstruction because of this gallstone, usually at the bulb, and treatment here is duodenoplasty or pyloroplasty. So you do duodenostomy or pyloroplasty. Now coming to question, All of the following statement about gallstone Ileus are true except Bouveret syndrome occurred due to impaction of gallstone in the duodenum. This is true. Tumbling sign on X-ray is a classical feature. Again, this is true. Longitudinal enterotomy is made at the site of gallstone impaction and the stone is removed at the site of gallstone impaction. So this is not a correct statement. Last statement, cholecyst to enteric fistula is not resected if there are no residual stone in the gallbladder. So if there are no residual stone in the gallbladder, you do not dismantle the cholecyst to enteric fistula. And if there is stone and the patient is stable, you can operate this in same sitting. Okay, so answer here is C. Longitudinal enterotomy is made at the site of gallstone impaction and the stone is removed.